Subcommittee on Public Health will come to order. Will the clerk please call the roll for today's attendance?
Chair Green.
Present.
Vice Chair Kuhn. Representative Maddock. Representative Slaw.
Present.
Representative Steele.
Here.
Vice Chair Price.
Here.
Representative O'Neill.
Present.
Mr. Chair, you have a quorum.
Vice Chair Price makes a motion to approve the May 13, 2025 minutes. There being no objections, the minutes are approved. And we're going to move into today to our hearing and testimony on one of the rather large initiatives our state has undertaken, which is infant and maternal health. And with that, I'd like to ask Sydney Brown, the House Fiscal Analyst, to talk about this portion of the budget and how it interacts and across many different aspects.
Good morning, Mr. Chair, members of the committee. I'm just going to do a very brief overview of maternal health because we have a lot of speakers today who are probably more knowledgeable than me. I'm just going to touch on the pregnancy prevention, prenatal, maternal health programs that are mainly in the family health services unit of the public health budget, but there are a number of lines that achieve the goal of the Healthy Moms, Healthy Babies initiative and maternal health in general. So starting with the Family, Maternal, and Child Health Administration, this has 49 FTE positions authorized with a gross appropriation of $10.3 million, and $3.6 million of that is general fund. This is funding for FTE positions, contractual services to administer programs for families and children, support newborn hearing and screening and early hearing detection intervention for newborns, reduction of infant mortality, the Michigan Model Comprehensive School Health Education Curriculum, the Children's Healthy Exercise Program, local administrative services, and the Child and Adolescent Health Centers, which have their own line. In fiscal year 25, so in current year so far, $4.8 million gross has been spent. Moving on to the family planning and local agreements, this in fiscal year 25 has $15.8 million gross appropriated, $7.3 million of that is general fund. These are grants to local health departments, including federal Title X funding for statewide family planning services, reproductive health assessment, comprehensive contraceptive services, health education, counseling, referral, and funding for special projects for like training and sexually transmitted disease testing and education. In fiscal year 25, $12.2 million gross has been spent so far. Moving on to local maternal and child health grants line, $7.0 million of this is federal Title V maternal and child health block grant funding. This is grants to local health departments on a per capita basis for locally identified service needs, such as prenatal care, immunizations, well child visits, and programs to address high infant mortality. In fiscal year 25, so far, $4.7 million has been spent. Next is the pregnancy prevention program, $1.3 million gross. 602,100 of that is federal Title V CDC grant money, and then 695 that is restricted Healthy Michigan Fund funding. This line supports grants to local health departments for family planning, primary pregnancy prevention services, training, pregnancy risk assessment, maternity mortality, and expanded programming beyond the Title X family planning program. In fiscal year 25, $372,000 gross has been spent so far. Moving on to the prenatal care and outreach and service delivery support line. This has 19 FTEs authorized, $43.4 million gross. $27.4 million of that is general fund. This funding supports FTE positions, related costs, grants, and contracts for prenatal programs, agencies for local maternal health, early childhood home visiting programs, which includes Nurse Family Partnership, who we will hear from today, Early Head Start, Healthy Families of America, prenatal support services to at-risk families, pregnant women and teenagers in communities with high infant mortality rates, And federal Medicaid matching funds for nurse-family partnerships are also part of this line. In fiscal year 25, $21 million gross has been spent so far. I also included the special projects line because in this area it does have a lot of maternal health programming that runs through it. So this is grants and contracts for maternal and child health. This line, it was allocated $6.8 million gross, $217,900 of that is general fund. This line has money for programs like fetal alcohol spectrum disorders program, maternal mortality surveillance, prenatal care, and fetal infant mortality programs, prenatal smoking cessation, a program to address behavioral and developmental needs in children birth through age 5, regional prenatal care and delivery of newborns hotline, among other programs that I've listed. In fiscal year 25, $2.5 million gross has been spent. Moving on to the sudden and unexpected infant death and suffocation prevention program. This has $321,300 allocated. This is federal money, Title V. This funding goes towards autopsies, grief counseling, referral services for parents who have lost a child to sudden and unexpected death, infant safe sleep, suffocation prevention, and risk reduction education for the public. In fiscal year 25, so current year, $51,600 has been spent so far. Moving on to the two WIC lines, you have the WIC Administration and Special Projects line, which includes 42 FTEs, $19.7 million gross, $18.3 million of that is federal WIC funding, and $1.4 million of that is private funding. And this supports the FTE positions for the administration of the WIC program and local agency infrastructure. In fiscal year 25, $9.5 million gross has been spent. Moving on to the other WIC line, this is the local agreements and food costs line. This is $251.3 million gross allocated, $190.5 million of that is federal WIC funding, and $60.8 million is private formula rebate funding. These are grants to local health departments and other agencies to provide WIC and infant formula counseling and education on nutrition, health, breastfeeding to at-risk pregnant women and new mothers. Participation in 2023-24 averaged around 189,226 women and children. Those are preliminary numbers. This is a decrease from the 22-23 year where the participation averaged around 205,875. And in fiscal year 24, $136.4 million has been spent so far.
Thank you, Ms. Sidney. Now, looking at some of these numbers, my quick math shows around $40 million is state GF. Majority of this funding is federal. Is there a federal match, federal drawdown, or is the GF just all completely discretionary?
So for some of them, there is federal match. For the CDC grants, it depends on the grant. For some of them, it's just research-based, so the state will provide data to the CDC in exchange for that funding. In terms of Title V, I believe, which is the Maternal and Child Health Block Grant, there is a match of $3 state dollars for every $4 received. And then for the Medicaid funds, the Medicaid Title 19 funding, I believe, that you have to have a 50% state match for administrative costs. And then the rest of that is just made up by the FMAP.
Okay. And then looking down at the WIC program, almost all of that is federal funding, but then there's private funding alongside of that. Mm-hmm. Can you talk about the source of the private funding?
Mm-hmm. Most of the private funding, I believe, comes from formula rebates. So the manufacturer of infant formula provides rebates that feed into that line.
So they sell a tub of formula, and then they send a portion of that to the state, and that's going to be a restricted fund that must go to the WIC program. Am I correct?
That's a private fund, but yes, you're correct.
It's a private fund.
Yeah.
Okay. All right, thank you. We have several presenters that are looking at, again, this important aspect. And we're going to start out with Dawn Shanafelt, the Director of the Division of Maternal and Infant Health in the Department of Health and Human Services. Dawn, thank you for being here today. I appreciate the color of your jacket. Some people think it has to do with a university locally, but I know it's for me.
It's for spring. Yeah.
Oh, it's for spring. Oh, okay.
Well, thank you so much, and I appreciate the opportunity to talk with you all today. As was said, I'm Dawn Shanafelt, the Director of the Division of Maternal and Infant Health, and I'm also Michigan's Title V Maternal Child Health Director, and you spoke of many of our Title V efforts here a moment ago. So the slide shows the mission that guides the efforts of the Michigan Department of Health and Human Services. And here, you'll see our infant mortality rates. Infant mortality is defined as the death of a live-born infant prior to their first birthday. Sadly, infant mortality affects the lives of hundreds of families each year in our state. We, however, have achieved historic successes in saving the lives of babies. In 2019, the infant mortality rate was the lowest on record for the state of Michigan. In 2021, we achieved another lowest on record. What do the 2 decimal point differences mean? It means that 38 more babies were able to celebrate their first birthdays with their families. Now again, in 2023, Michigan achieved another historic lowest on record infant mortality rate, with 49 more infants celebrating their first birthdays and filling 2 more kindergarten classrooms. Together, we are making positive changes in our state. As we pause for celebration, we must continue to delve further. In 2023, 600 families' lives were forever changed with the loss of their babies. The map to the left shows the 10 prosperity regions in Michigan. The chart to the right shows the infant mortality rate for each region. Region 3, or the Alpena area, has the highest infant mortality rate, followed by Region 5, the Great Lakes Bay area, and finally, Region 7, where we're sitting here today. There's geographic difference, as you can see, in the infant mortality rates across our state. We also see demographic differences, as shown by the 4 different infant mortality rate lines on this slide. Michigan should have 1 line. It should not matter where you live or who you are. All infants should be able to thrive, celebrate their first birthdays, go into kindergarten, and live happy lives. The causes of infant death in Michigan primarily fall into 3 categories that you can see here: perinatal conditions, sleep-related deaths, and congenital anomalies. Perinatal conditions are the result of maternal complications primarily, which is why it's so important to focus on the mother-infant dyad. Michigan boasts the long-standing and possibly the oldest, we believe it's the oldest, maternal mortality review committee in the nation that started in the 1950s. We review every single maternal death. Maternal mortality is defined as the death of a mother while pregnant and up to 1 year after pregnancy. There are approximately 90 maternal deaths each year in Michigan. Be reminded that while 90 may not seem like a high number, to the 90 families that are impacted by the loss of their mother, the family trees are forever changed. Currently, we receive funding, federal funding from the CDC and HRSA to support our maternal mortality review program. Each case is carefully reviewed by a team of experts, and every effort is made to honor the lives of the mothers lost by trying to prevent future deaths. The ray of hope can be found in the center of this slide, where you see the green, blue, and gold. Over 80% of the maternal deaths have been deemed preventable by the Maternal Mortality Review Committee. To look closer into maternal mortality review, or maternal mortality in Michigan, you can click through the data on our website, and this is a new option for individuals interested to delve further. You can see the maternal mortality review rates, or numbers based on year, area of the state, causes of the death, and much more. Severe maternal morbidity, so we're going to switch gears a bit, has been coined a near miss, essentially meaning that the mother did not die but was very ill and potentially close to death. This slide shows, again, geographic variation, with the Upper Peninsula having the highest rate of severe maternal morbidity in our state. Maternal mortality rates also vary by geographic area, with East Michigan, Region 6 here, or the thumb, and Region 5, Saginaw Bay Midland area, having the highest or greatest rate of maternal mortality. But the greatest numbers, or the highest numbers when you're looking at hard numbers, can be found in Region 10, which is the city of Detroit. So what has Michigan done to save the lives of mothers and newborns in our state? Well, first off, the Alliance for Innovation on Maternal Health, or AIM, was launched nationally in 2015. Michigan was one of the first states to participate. Michigan AIM, or My AIM, implements proven safety bundles to help prevent emergencies and address them if they happen. The preparation is akin to emergency preparedness. We certainly hope that there isn't a tornado near our home, but if one happens, we're as prepared as we humanly possibly can be. My AIM is currently implementing 4 bundles: hemorrhage, hypertension, sepsis, and substance use. My AIM hospitals run drills, train their teams, have the needed emergency equipment readily available, and collect and analyze related patient data to identify areas for improvement. Too many papers. 89% of Michigan's 75 birthing hospitals participate in My AIM. That's a huge percentage and number that's risen over the past couple years, with the majority implementing the major 3 safety bundles that I spoke of: hypertension, hemorrhage, and sepsis. The reason for these 3 bundles are that these are 3 of the top causes of death and maternal morbidity and mortality, as well as substance use or overdose deaths. 3 Upper Peninsula hospitals are piloting the substance use disorder bundle. And I want to be real clear, My AIM works. The state severe maternal morbidity rates for both hypertension and hemorrhage have decreased since before My AIM was launched, which you see from 2011 through 2015, that was before AIM, and then now after AIM, 2019 through 2023. There's a difference. And each of those percentages is, again, a life saved. Next, regarding hospital efforts that are being done, or clinical efforts, the Joint Commission and the American College of Obstetricians and Gynecologists, or ACOG, which you're probably all familiar with, Maternal Levels of Care Designation Program, improves the lives of each individual patient that's seen by assuring that there's standards of care that are implemented within hospitals. This program standardizes and improves maternal care by designating hospitals based on their ability to manage various levels of maternal risk. As in typical Michigan fashion, we were a leader in launching this program. Georgia, Florida, and Missouri are also implementing, with Michigan having the highest percentage of hospitals participating in the first year, which was last fiscal year. We began funding this effort in fiscal '24 and implementing the Maternal Levels of Care program in conjunction with maternal quality payments. Of the $10 million allocated to this budget line item, $9 million are earmarked annually to go directly to the qualifying hospitals. This investment is truly life-saving, resulting in the ability of hospitals, as I said before, to run drills, purchase the necessary emergency equipment that they need, such as hemorrhage crash carts, train their clinical teams, and specifically have the dollars that are needed to fund the time of a nurse or physician to pull the data and extract it and monitor what's happening safety-wise within their facility. And then also identify the gaps. So when you run a drill or there's an emergency event and you see that there are areas for improvement, you make those improvements. It's critically necessary to retrain the staff and do what's needed. If a woman is delivering a baby and she's hemorrhaging, you need blood there immediately. Time is of the essence. So these drills and trainings and delving into their data, again, they literally save lives. When an emergency happens, you have to be ready to act quickly. Related to that, in the last bullet on this slide, maternity care deserts, they're an issue in Michigan. When I started this position over 10 years ago, there were 85 birthing hospitals. We now have 75. We're soon going to have 74. And then we've also heard of another one that plans on closing within the next few months. So you see here, Keweenaw is slated to, or has already closed in December, their birthing unit, and then Tawas is closing their birthing unit in July. So Medicaid pays for 45% of the births in Michigan statewide, with that figure increasing substantially in rural areas. For example, 61% of the babies delivered at Munson Hospital and Cadillac are covered by Medicaid. Rural hospitals are under financial distress, have been forced to eliminate essential services like labor and delivery, which not only affects Medicaid beneficiaries, but disrupts access to entire communities. In rural areas, the local hospital is both a critical healthcare provider and oftentimes is the largest employer. Nationally, rural hospitals in non-expansion states have closed at significantly higher rates, with hospitals in those states 6 times more likely to shut their doors. By contrast, in Michigan, we've expanded Medicaid, and that's resulted in more stable hospital finances, preserving access to care, particularly emergency rooms and maternity care, where time is of the essence. With Michigan's, you all know this, with our ever-changing weather, and even on a good day when it's sunny out like today and driving is quicker than usual minus construction, it's still an issue to get from point A to point B. And the birth date of a baby is rarely known or planned. So the services are needed as close to the homes as families as possible. So if someone goes into preterm labor, that family needs to get to the hospital as quickly as possible. And when you have hospitals closing, particularly closing their birthing units in rural areas of the state, that's a problem. And you toss in an ice storm, like in Gaylord, or a snowstorm, and it's even of more concern. I'm going to switch gears to centering pregnancy. Centering pregnancy is also funded by Healthy Moms, Healthy Babies. It's a group prenatal care model. It decreases the rate of preterm and low birth weight babies, increases breastfeeding rates, results in pregnancy spacing being longer, which is better for moms and current baby and subsequent babies. And it has been shown to improve detection and treatment of postpartum depression. Essentially, it's a sense of community and support, which is important for all of us. It is needed, especially during that crucial time of pregnancy, postpartum, and having a new baby or early infancy. Being part of group prenatal care results in support, friendships, a sense of community, and patients feeling heard, respected, listened to, and bottom line, better health outcomes. Last fiscal year, the investment in centering pregnancy resulted in 21 new sites for patients to choose prenatal care from. So from Detroit to Saginaw, Hazlitt to Muskegon, we have new sites. So far in this current fiscal year, there are 6 new sites embarking on the process to become centering sites. Centering, again, is an evidence-based model, and it's overseen by the Centering Health Institute. Munson Healthcare, an amazing effort by Munson, has committed to launch new sites. They currently have 3 on track to launch and open. And we're focusing on rural Michigan this year regarding centering because we know that the percent of isolation, loneliness, and depression are really prevalent in the rural areas of our state. I'm going to briefly touch on home visiting because I know we also have other speakers that are going to be talking more in depth. But our state is fortunate to have 8 evidence-based home visiting models. This allows families the ability to choose the model that best meets their needs, whether they want weekly visits, monthly visits, need the assistance of a social worker, want the support of a registered nurse, or prefer trained parents to support them during this important time of pregnancy. Michigan, our home visiting system, has something to offer. Each year, close to 20,000 families are served with over 150,000 home visits. Healthy Moms, Healthy Babies has also resulted in streamlining access to home visiting services, whether it be for families having the ability to self-refer when they log into MyBridges or go to our MyBridges website. They call 211 or go to the 211 website, or something I want to touch on that's very innovative, I think, and it opens a lot of doors for families, is our partnership with Philips and their Pregnancy Plus app. Michigan has collaborated with Philips to have the worldwide app tailored to Michigan families, which I think is really cool. Close to 6,000 families with Medicaid insurance use the app every month, and over 30,000 families across the state. So the app is free. You download it on your phone. You can take it with you wherever you go, obviously, because most people take their phones with them wherever they go. And it asks where you're located. It doesn't do any tracking or anything like that. But if you say you're from Michigan, you're going to see Michigan resources when you're utilizing the app. You mentioned WIC today. You're going to see that where do you sign up for Michigan WIC? Where do you get insurance if you don't have insurance? Where can you find a diaper bank? Where can you find formula if you run out? Where can you find a pack and play? All the things that new families need, you can be linked to those by utilizing the app. And in addition, you can see what your developing baby may look like. And it's actually very... It's used worldwide, but it's very innovative. So you can track things within the app yourself. No one's tracking you, so I want to make that clear. But you can see what the developmental stage is of your fetus. You can get a list of things in preparation, right? We know that the waiting lists are long for childcare. Just a host of things that really helps new families be able to prepare for a delivery. We're going to shift gears again because that's the theme of this morning or my presentation. Michigan's Perinatal Quality Collaborative is comprised of 9 regional collaboratives. They are also funded in 2 parts. They're funded by primarily State General Fund, and we receive a small amount of money from the CDC for our Michigan, we call it PQC. The map to the left shows the regions, noting that regions 2 and 3, you see that they're both green. That's because they work together as one region. They did that prior to our efforts in the state, and that's been very successful for them to work together as one. The purpose of the Michigan PQC is to improve birth outcomes, partner directly with families, and to unify, resulting in healthy moms, healthy babies. Michigan's PQC assures that families are the experts in the leads, which they are. The regional perinatal quality collaboratives are working together to address perinatal substance use disorder, improve cardiac care outcomes, support fathers, link mothers to mental and behavioral health supports, increase breastfeeding rates, remove barriers such as transportation, link families to services, and just a host of other things. The RPQCs really embody the African adage, it takes a village to raise a child. Really, it's everyone coming together to make things better for moms and babies in our state. Aligning and unifying our efforts under the direct advisement of families. I want to make that clear. We work on behalf of families, so that's where we get our advisement from, and we respond to what we hear from families. That's where you'll see, and you are seeing, based on what I've shown you in some of the rates, tangible change here in Michigan. $5 million of the dollars that goes to the regional perinatal quality collaboratives is marked as one-time funding, and it goes directly to maternal and child health efforts in the hometowns and cities across Michigan. It comes from the state and goes directly to the streets, which is where it needs to go. This fiscal year, 125 agencies and programs were awarded funding to offer a variety of things, including childbirth education classes, breastfeeding support, support infant safe sleep initiatives, mental health training, supporting healthy pregnancies, infant CPR, and the list goes on and on. These entities are making a huge difference, right in, like I said, their hometowns and in the cities throughout our state. Gear switch again. We're going to move into doulas. Doulas provide non-clinical, emotional, physical, and informational support to pregnant women and their families, both during pregnancy, postpartum, and beyond. In January of 2023, Medicaid began reimbursing for doula services. By 2024, the Michigan Doula Registry had 298 doulas listed, with 178 enrolled in Medicaid and able to accept Medicaid insurance. That's really important because previously families could only get doula services in Michigan if two things: if they had cash and they could pay for them or pay for the services, or they happened to stumble upon the very rare occurrence that there was an entity that had grant funding that could provide doula services, such as Black Mothers Breastfeeding in Detroit Association. They had a small amount of money and could help with a small number of doulas. Now it's grown across the entire state. And doulas have been around for hundreds of years, and they work. So by January of 24, as I said, you see on the left here, the number of doulas in Michigan. Now, as of January of this year, we've grown exponentially. There's 643 doulas available to Michigan families, with 403 of those enrolled with Medicaid. But it actually even gets better. So as of May 14th, so we'll fast forward to last week, there are now 750 doulas on the registry. So what this means is access for families to doulas. It also means people having employment as birth workers, having the ability to bill Medicaid, having the ability to see families, having the ability to partner with hospitals. Hospitals from around our state work with doulas as well, so it's very important. So as I said, May 14th, there were 750 doulas on the registry, with over 500 being enrolled in Medicaid. To find a doula, you can go to our website, click on the map, you pull up your county, and you can see the doulas that are serving your area, and that's important for prenatal care providers as well, too. The nurses and staff of the prenatal care clinics help link families or patients to doulas, and they're able to pull up and say, you know what, there's 50 doulas in your area, and we can help get you connected. The Michigan maternal mortality, the Michigan maternal and infant health efforts in our state are data-driven, they're family, community advised, and they're working. The cuts currently being proposed at the federal level threaten to reverse this progress, compromising health outcomes, straining the remaining healthcare infrastructure, and driving up rates of maternal morbidity, mortality, and uncompensated care. Maintaining robust Medicaid support is essential to protecting Michigan's health safety net and ensuring continued access to life-saving services. Like I said, if you're in northern Michigan and you lose your hospital, that's life-saving services, not just for maternity care. If a hospital closed down and you have a heart attack or a stroke, you know, I'm a nurse, you need to act quickly. A bad car accident on 75. We don't have the time. When it's an emergency situation, you need to be able to respond quickly and have the needed clinical services and the needed number of ambulances available to take people to where they need to be. And so with that, again, this is extremely important and critical for beyond maternal and infant health. Michigan investments are critical. We've invested a lot in maternal and infant health because we're committed to families in this state, and you can see that it's making a huge difference. So with that, I'm happy to take any of your questions.
All right, I have some technical questions for you.
Sure.
This is a very, very general question. This is zooming way out.
Okay.
When we define infant mortality, consistently, I have friends that live across the world and doing missionary work and so on, family as well.
Wonderful.
Consistently, world rankings show that America is doing poorly as compared to other nations in infant mortality rate. That being the case, are we comparing apples to apples? And what I mean by that is, does the whole world define infant mortality in the same definition? And then the other portion of it is, does the whole world have access? I mean, we've talked about critical access hospitals in rural areas. I have a sister lives currently in South Africa. Okay. They don't have critical access out in the bush. So when we are looking at stats, we're ranking such, are we dealing apples to apples, or are we, because America is so robust in our education and in our healthcare, we are reporting, we have the capacity to report better? Does that make sense?
It makes perfect sense. So first of all, I'm going to give you a disclaimer. I'm not an epidemiologist.
Okay.
So I'll answer from a program perspective, from a nurse and maternal infant health, somewhat expert. So infant mortality is defined as the death of a live-born infant prior to his or her first birthday. And so no, we are not dealing with apples to apples for a variety of reasons. One would be, I'll start with live-born infant. So in the United States, we have excellent life-saving efforts for preterm and low birth weight babies. We can't save every baby by any means. Some babies are too tiny, sadly, and too small to survive. But we have excellent life-saving efforts. Close to 98% of the babies in Michigan are delivered in a hospital. So evidence of life may or may not be, I don't want to, again, I don't work around the world, may or may not be detected in some other areas. That could potentially be something. We know that we can potentially save a baby that's 23, 24, 25 weeks, right? In some areas, it may not be deemed as part of their infant mortality data. That's one piece. And then you were spot on when you said we have the ability to collect excellent data. So that's something the United States excels in, and in other countries as well, too. So again, it isn't necessarily apples to apples. However, we have challenges in the United States, which in a variety of different areas where we see differences in asthma rates, chronic disease rates, maternal mortality, maternal morbidity, high school education or graduation rates. I mean, there's some challenges in our systems and how they were built in the U.S. that result in poor health outcomes, in addition to there is variation.
And then as we drill down into data, it appears in our, I think they're split up by the prosperity regions, am I correct? In our prosperity regions, Region 3, Region 5, and I know we have a speaker from Region 5. Basically, if you start in Lansing and work your way up the East Coast, those numbers seem, those colors seem much more intense on your colored chart. Can you give us specific reasons as to why? What are we finding? Is it because they're close to Lake Huron? Is it substance abuse? Or what are some common themes that cause the challenges in that east and northeast regions?
There's a variety. Poverty would be one. There's isolation and vast geographic distance when you think about providers and access to providers. So we know in those areas of the states, we have challenges with the number of mental and behavioral health providers that are available, the number of clinicians that are available. For the sake of this presentation, OBGYNs, pediatricians, You mentioned newborn hearing screening a bit ago when we were reviewing the budget. Even access to audiologists for kids in those areas, number of hospitals in those areas. So there's definitely a deficit or a lack of access to critical services. But also you mentioned substance use, and we have some higher substance use rates too when you look in the thumb area. Safe sleep, I mentioned. The Alpena area has higher number of infant safe sleep deaths compared to some other areas of the state, as does the Saginaw Bay, Midlandish area. So there are definitely some challenges that the families are faced there. And if you've all probably driven out in those areas, I mean, you can drive for a long time and see, I mean, windmills or whatever, I mean, and before you come across areas where help and services can be obtained.
Vice Chair Price.
Thank you, Chair. Thank you for coming in from the department today. You mentioned data, and we know last session we both passed legislation and invested funding in various tools to help improve birth outcomes in Michigan. Wondering if there are any preliminary returns on our investments for any of these measures. Is the data and progress being tracked?
Definitely, I think there's return on investments. Every single life that's saved is a return on investment to me. And as far as data and tracking, we have the maternal mortality data tracking map that I showed you just a few minutes ago. That's something that's new, so we can track specifically. We've always been doing a lot of that tracking at the state, but now the public can see that information. Now those that are working with families can see that information. What's happening in the areas of the state where people live. So yes, definitely. And then I mentioned the maternal levels of care verification program. The nurses in our division are working to put a map on our website that will show where all of the birthing hospitals are in Michigan, which we think will be extremely valuable to families. So when you're deciding, families look at communities to live in, right, based on where the school systems are, if they have a good schools, or they like the neighborhood, or a host of things. They also look where hospitals are and where healthcare is, and where they can take their kids to the pediatrician, and all of those types of things. So it'll list all of the hospitals in the state that have a birthing unit, and then it will also list the maternal level of care. Because the bulk of our hospitals, as I shared, I went through the maternal levels of care verification. So you'll be able to see, so if I'm someone who was born with a heart defect, I probably should be closer to a hospital that has excellent cardiac ability and excellent, when I go to have a child, or this is hypothetical, I'm past childbearing time. But anyways, you'll have additional information right at your fingertips, because that's really important. So yes, the investments are making a difference. Transparency is important to families, right? You trust the state, you trust government when you have the ability to get questions answered and be able to see where your tax dollars are going. You're welcome.
Representative O'Neill.
Thank you, Mr. Chair. And you made a comment about you have a sister that lives in South Africa. I didn't know that. But thank you, Madam Director, for being here. I just want to just kind of highlight what you just mentioned in terms of the multiple factors that contribute to various conditions, particularly infant mortality. Mm-hmm. And I live in Region 5. I'm from Saginaw. And so, but what's still alarming to me, and it's pretty consistent, from your 9-year chart, 2014 to 2023, the black non-Hispanic rates are way above 10% consistently over a period of time. So that says a lot to me, that the standard of care is not the same in those individual cases. And so why do you think it's that way for so long, as being an expert, a doctor in this field? You've mentioned some of the factors, but I have a personal story. My daughter,
I remember,
she flatlined twice. And my granddaughter, she's 2 years old now, but she said, "Dad, I tried to tell them something's wrong, the doctors." She said, "They didn't listen to me." Okay, so there's a major problem here. Just consistently, the outcomes are different from a white woman to a black woman. They see the same doctors, they go to the same hospitals. So, I mean, we can do better.
Absolutely, we can do better. As I said, there shouldn't be 4 lines that you see on the chart that I shared. There should be 1 line, right? What the outcomes are for Michigan families. It shouldn't be broken out based on race, ethnicity, where you live in the state. We should be having the same standard of care throughout the state of Michigan. But we know, and this is said in other presentations, this is a challenge the United States faces. There's variation throughout the United States and where it's the healthiest state to live or healthiest area to live. So things such as, so in your daughter's case, and I remember the heart-wrenching story that you shared last year when I first heard your story. And again, I'm so grateful that your granddaughter's now celebrating your second birthday and your daughter's okay. The emergency preparedness that I spoke of and standards of care that I spoke of, those are really critical because we're all individuals. We're humans. And medicine is primarily been, paternalistic system where I'm almost 56. You listen to what the doctor tells you. If the doctor says everything's okay, then everything's okay. Doctor tells me I need to take this pill, then I take this pill. There wasn't a lot of questioning and I said I'm a nurse, but even when I'm in a room with a doctor, I ask half of the questions that I'm supposed to ask or that I think I'm going to go in there and, do you know what I mean, ask about. There's definitely a hierarchical or I don't know, I don't want to use the word oppressive, but it is like you could tell the power dynamic. Mm-hmm. There's a reason that individuals stand up while we're sitting, while we're on an exam table. There's something happening. And we have amazing doctors, so don't get me wrong. There's systems that are built, and as a result, we see difference in outcomes. So there's differences in care. There's individualized decisions made. We know that women, for example, if they show up to the ER with chest pain and heart attack symptoms, our heart attack symptoms are different, for one thing. I might have back pain by my shoulder blade or indigestion. That's not your typical, when you think about heart attacks, that's not what you see on TV, with the chest pain and you're holding onto your chest. We need to look at individuals as individuals. And again, they are the experts. We are literally inside of ourselves, right? So we're the experts. You need to listen to the experts. And that's what things such as, I mentioned AIM and maternal levels of care, yes. That's what they're teaching and checking for. So it's one thing to teach and say you should do these protocols. It's another thing to have chart audits done and to follow up when a bad outcome happens. So a mom hemorrhaged at a hospital in Detroit, go backtrack and look at what potentially led to that. Mom came in anemic, or the blood wasn't there in time, or just a host of things. So I think that's where Michigan's doing really well. I know. We're investing in the long-term solutions here. This isn't a short-term problem. If it was, Michigan and the United States would have great outcomes. We don't because it's a complex problem.
Yeah. Thank you.
You're
welcome.
welcome.
Mr. Chair.
And last question for you, Representative Steele.
Thank you. Just real quick, if a pregnant woman were to get in a car wreck, mm-hmm. Is she included in that statistic?
Yes, she is.
So it's not necessarily about care per se or drugs or infant mortality. It's about getting into a car wreck.
In that case, it would be. But I can tell you when you look at the overarching numbers of the 90 deaths in Michigan each year, the bulk aren't related to isolated incidences such as car crashes or drownings or homicide. The bulk are related to some sort of medical challenge that resulted, and that includes perinatal substance use disorder, and the deaths can occur primarily they occur during pregnancy, but between 1 and 42 days postpartum. So yes, they are included, but it's an extremely small number. I don't have the numbers offhand, but I can tell you that.
So it could be unrelated completely to being pregnant.
It could be unrelated, yes.
And so that might skew the number a little bit to make us look like that we're higher as a nation.
It's not going to skew it very much based on the hard and fact numbers. The bulk are related to medical health conditions during pregnancy and postpartum.
Okay, and then another thing that you said, 45% of all births in Michigan are Medicaid?
Correct, Medicaid covered.
And then how is that number? Is that number going up or down? I would think that Medicaid was designed to be aid for a while. Mm-hmm. So are we making progress in that capacity? So what has it been over the last 10 years?
I can't tell you because I'm not the Medicaid director. I will say, just in general, the percent of pregnancies that are covered range between 40 and 50%. So again,
so that you don't know if it's moving up or moving down.
It's, for the most part, it's staying baseline, but it's moved down from what it was previously. if that makes sense. So I've been doing this work for, I don't know, 20 plus years, 30 years. The percent has moved down as far as the percent of births that are covered by Medicaid has decreased over time. What it's been over the last 10 years, I'll get the information if you'd like, so you can see that
I
specifically.
would, thank you.
Yeah, absolutely.
Thank you so much.
You're welcome.
We've covered a lot of ground, and I'm sure that each and every one of us could probably set up a meeting in our office with you and go over more questions, but thank you so much.
Absolutely, thank you all, I appreciate the time.
Our next presenter is Amy Zagman, Executive Director of the Michigan Council for Maternal and Child Health. And again, appreciate the colors, supporting the...
I got the memo. Dressed accordingly. Thank you, Chair Green and members of the committee. I, in the nature of not wanting to just repeat what the good information you've just heard, you may see me skipping around my notes, and hopefully that will be appreciated as far as efficiency. But I'm Amy Zagman. I've been with the council for around 16 years. The council's been around for a little over 40 years. And you can see our current members listed on the back of our policy agenda. But we're really have come together really to put medical care, community services, and public health at the same table to talk about what will it take to improve maternal and child health in the state of Michigan. I'm here today just to talk about, obviously, the public health portion of the FY26 budget and focus on maternal and infant health, but many of the things that Sydney talked about that are funded in the budget, if you want to talk more about those kind of things, we'd love to talk about comprehensive health education and things that impact older audiences, but today I'm going to focus on maternal and infant health. You'll probably hear me talk about a lot of the same things that you just heard about from the department, but I would like to really give voice to providers and to the families that they serve, because we don't just always agree with the department. We work with them. Sometimes we challenge them, and hopefully I can share with you some of the things that we think are making a difference from a provider perspective. Because of the bipartisan focus on maternal and infant health the last few years, there's been significant investment, and we think it's showing progress. As you already heard, we have cause to celebrate with our lower infant mortality rate. But if I had a key message for you today, it's that we have to sustain these gains. We just talked about the complexity of the problem. What we can't do is search for the one thing that's going to make a difference. We have to do all the things. It has to be a yes and. We've got to be persistent and consistent if we want to move forward on behalf of moms and babies in our state. That, I think, would be my primary message from providers, is don't fund something one time and expect that providers are going to jump in and start new programs or a different model of care. They're hesitant, they're cautious, they're overworked already. And so what they're looking for is a commitment from the state that if I change this about my practice, or I invest in this new model, or if I make these changes, you're going to be there this year, next year, and on. Yes, they want to be judged. They want to collect the data, as we talked about. We want to see improvements, but we need to know that these are long-term, hopefully not intractable, but difficult to move issues. And so we're doing the work to help ensure healthy births. We want more children to be born healthy. And so I'm going to mention a few of the same things that Dawn did, but just to tell you how the providers are feeling like they're making a difference. So with regard to doulas, and you have, I brought with me a folder today. It has a lot of hopefully helpful information just to break down what some of the things are that we're talking about, and also give you some idea about how the dollars are being used on the ground. I'm not going to talk a lot about doulas. I think doulas are doing a great job in the state of speaking for themselves. But I will say that providers in the state have embraced doulas. It's not always easy, right? Doulas are not healthcare professionals, but they're put into healthcare spaces to help individuals navigate. And we know that when there's a doula involved, there's better outcomes. There's lower C-section rates, there's lower postpartum complications, lower rates of preterm birth. And while we absolutely want all of those things, they also save money. And so, doulas are doing the work of helping improve healthcare outcomes. They work in a variety of capacities. They can be focused just in the postpartum or grief space. In Michigan, we've added Medicaid coverage for birth doulas, and some of the funding that you see in the budget is the general fund that's needed to match Medicaid. So the investments that the state has made in the doula advisory, scholarships to help doulas become certified, I think from Dawn's numbers you can see that's all making a huge difference as, empowering this workforce to actually be available. I wanted to read a quote from a doula who's working in the Grand Rapids area. She's been in this space for a long time. The landscape for doulas in Michigan has changed dramatically in just a few short years. There's much more public recognition and institutional interest in our work, but that doesn't always translate into sustainable support. Many of us, especially Black doulas, are still having to fight for legitimacy in systems that weren't built with us in mind. The reality is doula care has always been vital in our communities. We're just now demanding and seeing it being valued accordingly. So I think, again, that message is being sent that if we value these things, let's help support them, and we need to be consistent about it. I'm going to shift to talk about centering pregnancy, and Dawn did a great job explaining centering pregnancy. I think the same way that doulas are easy to understand, right? It's like easy to understand how someone helping you navigate the process of a pregnancy that for many of us, right, it's the first time you're doing it, or it's always a high stress time. Having doulas definitely makes sense to folks. I think group-based prenatal care inherently makes sense as well. It's not difficult to understand that if you've been put into a group with individuals who have similar due dates as yourself, and the model where you're receiving time with a clinician, just like you would at a normal prenatal care appointment, but you're learning about essential pregnancy and parenting items like safe sleep, like lactation support. You're learning about those things in a group setting, but it's the magic is really the group itself, right? That you have a group of peers who are going through the same things that you're going through at the same time. And what we find is that, this sparks conversation and curiosity. It turns a regular obstetrics checkup into a learning and community building opportunity where people are supporting each other. They're forming friendships. They're getting rides together. They're talking about child care's challenges. All of the things that maybe used to, decades ago be happening at the community park. With a lower birth rate, it's a little bit harder for people to find each other. And I think centering pregnancy is a great example of sort of working against a society that's turned into really digital, right? It's great to have apps and things, but it's really nothing that can replace sort of that person-to-person interaction, especially at a time of such interest and learning and growth. So I gave you a handout that has centering pregnancy on it. It has the sites listed, so you can see if there's centering pregnancy happening in your district. But I would say that what has really made a difference, and we've seen this enormous growth from 13 sites before the state started making investments in centering pregnancy to now 34 with additional contracts on the way, is the startup funding. It does require providers to make a change in the way they provide services. So you're bringing in 8 folks at the same time. The clinician has to line up their appointments. They have to have a coordinator there who leads the educational session, and they have to have a space for folks to meet. So it makes, it requires an investment on the part of the provider who wants to put this model into practice. But again, the cost savings are in the better outcomes, and we do see better outcomes. There's almost a zero no-show rate for centering pregnancy. I think it's probably because of the way it's structured and because people feel such a sense of belonging. I don't know about anyone else, but like when I want to make myself exercise, I sign up for a class with a friend, and then you actually show up, right? So I think there's something inherent about centering that draws people in and keeps people doing things like attending their prenatal care appointments. Michigan has moved towards sustainability, right? It's not just about throwing GF dollars at a problem and being like, well, we'll see what happens. Centering pregnancy, because it is a prenatal care model, is Medicaid eligible. So now these dollars that are in the budget are being matched by Medicaid for Medicaid recipients. We would love to see more private insurers also come online, paying for the small additional cost of centering, because again, we know that the larger cost downstream in, avoidable NICU admissions and preterm birth, those things are borne out in the centering data, and so we know that those things are cost savings to taxpayers and to insurers. I wanted to talk about the perinatal quality payments for just a moment. Dawn did an amazing job describing the MyAIM, the Alliance for Innovation in Maternal Health, and the safety bundles that are being implemented at the majority of our birthing hospitals. We've been talking about MyAIM in Michigan for years. I've been at the steering committee table. And it's always been led by a core group of clinicians who want to do better, right? They want to avoid some of the things that we've talked about this morning. They want to really dig into those preventable maternal morbidity and mortality numbers. And they were, for many years, sort of going around and trying to cajole their colleagues at hospitals. Hey, could you get this going at your hospital? Could you take this on? And some did to varying degrees, but what really made the difference is when the state stepped up and started providing some funding, because sustaining this funding, it fills a gap. So every birthing hospital has access to the training and technical assistance so that we can be sure that that clinically appropriate, consistent response happens in every obstetric emergency. I think Dawn already did a great job of saying this, but I just like to think about if it's your wife, your sister, your daughter who's has a hemorrhage, you want them to get the same response no matter which hospital they might walk into. And so, making sure that this funding can help fill the gap. Again, I really feel like clinicians want to do the right thing. They often, if you think about it from a hospital perspective, are fighting internally for resources as well. We've targeted this resource right at the problem. We've said to hospitals, you can use this, and here's what you're going to use it for, and they are. And we would argue that it's making a difference. I brought you a handout from the Hospital Association that probably just reiterates what Dawn said, but it shows the difference that it's making in the time that we've had funding available to invest in the perinatal quality payments and the MyAIM initiative. We are seeing a difference in the numbers. Obviously, you can see the almost 30% reduction in severe maternal morbidity from hemorrhage. Interestingly, I don't know if we're going to talk about it today because I don't know which part of the budget it falls in, but there has also been a one-time project called SOS Maternity that is similar to MyAIM for the hospitals for outpatient providers, really to think about what can we do to standardize care in the outpatient OB setting to make sure that all of the most current standards of care and practice are being utilized in every setting so that we can improve outcomes. So I don't know if that's in this section of the budget. Sydney's nodding, yes. We would really ask the committee to strongly consider moving that funding from one-time to sustainable. Again, this is exactly the conversation that I just had, which is providers want to be engaged with the SOS network and the experts that come from our state's universities, but if they're going to take that opportunity to be engaged in the network, they want to know that it's going to be an ongoing, consistent approach. Dawn talked about the perinatal quality collaboratives. I brought you a handout that shows the collaboratives so you can identify where yours falls. I also gave you the contact information. I hope if you're not already in contact with your perinatal quality collaborative that you're interested in meeting with them. That's where the providers that I work with and others are sitting and talking about that regional data. You saw the differences. If we really want to get at the core of the problem, we can't, from Lansing, send out just one solution. We need to give them some flexible dollars where they can look at their local data, have local conversations about what are the gaps, what's missing, and what can we do locally through evidence-based strategies to make a difference. The beautiful thing about the way Michigan's set up is we've empowered the regions, but they bring their knowledge back to the statewide perinatal quality collaborative. So if it's another region has similar issues, they're able to work together. They're not necessarily just recreating the wheels in the 9 different perinatal regional collaboratives. They're learning from each other. I want to throw out one new ask rather than just reiterate the fact that we support much of the funding in the budget. Dawn mentioned home visiting and the 8 evidence-based models we have in the state. Not all models are available in all areas. About a decade ago, former State Senator and Congressman John Mulliner added money to the DHHS budget specific to ensure choice for families in rural areas. It's captured in Section 1311 of the boilerplate, and that funding has been stagnant at $2.75 million for many years. Obviously, costs don't stay the same with regard to staffing those home visiting programs, and we would ask that you consider increasing that amount to $5 million to make sure that we can keep pace and potentially also start another site in a rural area. This is important because not only do we want to have more services available to families, but I brought you a sheet. You asked earlier about federal match and where and when it's required. Michigan does receive some federal funding. It's called MCV, Maternal, Infant, Early Childhood Home Visiting, from the federal level. And we need to up our state contribution to keep our full federal allotment. So the state, in some way, shape, or form, needs to spend another $389,000 on home visiting if we want to keep our full MCV allotment. I was going to wrap up with pretty much the same thing Dawn said to you. We're really worried about what's going on at the federal level because federal funding, Medicaid, Title V, WIC, have always been so important to maternal and infant health outcomes. We're really worried about it. We're really worried that you're going to be put in very difficult positions and that instead of just sustaining the gains that we've made, we're going to be backfilling holes. So just know that we're really working hard to make sure our congressional delegations understands the importance and that it takes all of us to hopefully make a difference.
Excellent. We have one question.
Okay.
Representative Steele.
Just trying to follow this process. I mean, we are, I understand the programs and how they help, but, we are a budget committee.
Yes.
So with that, I guess my first question would be if 45% of the births are in the state of Michigan are Medicaid, how many births are we, like actual number of kids?
So I will also qualify by saying I'm an epidemiologist, but I look at the data quite often. In 2023, which is the last, the state has to clean data. You can appreciate that. It takes a minute to get the 2024 data I have not seen yet. But in 2023, we dropped just below 100,000 births.
Okay.
For the first time in since the 40s, I believe.
Okay, and then because I see that there is a centering pregnancy site in my town.
Oh,
and if you were to work backwards, so if I say, okay, I'm going to go, well, I'm not going to, but I'm going to go to this healthcare clinic, and anybody can go to it? And then how is it funded backwards? So is that funded by only through the state dollars and the Medicaid dollars or insurance dollars or all three? Is it contracted by the county? Does the county participate? Does the state pay for it or the federal government pay for it?
So I'll try and answer, but
I know we're running out of time real fast, but everything that you said, I can't follow how many people we're helping, how much does it cost, is it, and then how much per baby? I mean, and are we being effective with our dollars? So
I think each individual site, which have individual fiduciaries, so it would be great for you to maybe do a tour and talk to your site.
But they wouldn't know about the funding from the federal government to the state to the county.
Oh, that no. But specific to centering, they would certainly know if they're accepting if they're getting any other funding other than Medicaid funding, how they chose to fund the setup of their program, how many individuals they're serving, what that works out to per patient. They would definitely be able to help with that.
We're in a budget. And so we're trying to budget.
Rep, we need to wrap this one up.
Okay, and then that's just my concern, Rep. Green, is that following the dollars backwards to make sure that from what we started our whole meeting with to where we are with these sites and filling the gap with, but she's not prepared.
Yeah, I think at this second, we'll probably get more information and
Absolutely.
Answer that question more thoroughly. And thank you, Amy. Moving on quickly, again, we have a hard stop. We have committee coming in afterwards. Katie Liebler and Shawana Tyson, both from the Nurse Family Partnership of Ingham County. Okay.
Sorry, Shawana was unable to come today, so it's just me, Katie Liebler. Thank you so much for letting me come and present
If we can take, let me see here, we have about, thinking through, maybe 8 minutes?
Oh, yeah.
Okay.
Yep.
5?
Sounds
The
good.
boss has spoken.
I am appreciative of any time you're willing to give me. Again, like I said, I'm Katie. I'm the supervisor here for our Nurse Family Partnership Nurse Home Visiting Program in Ingham County. There are Nurse Family Partnership programs across the state, but I work for this one. I am a nurse myself. I've worked in a variety of different settings for maternal and child health, and I can tell you that working with nurse home visiting is soul fulfilling as a nurse because we get to do so much to prevent those bad outcomes that we're hearing about. My nurses on the day-to-day, I have 5 nurses on my team. They can serve up to 20 to 25 families each. Doing home visits for them. They might have 3 to 4 visits in a day. They enroll first-time moms in the early stages of pregnancy, so the first 1 or 2 trimesters of pregnancy, and they continue to see them about every other week until that kiddo is born and turns 2. So they're with families for a very, very long time. They build very close relationships, and they're really focused on good outcomes for mom, good outcomes for baby, and helping mom, reach the goals that she has. In a typical visit, they're going to do assessments to see if mom is having any health issues related to her pregnancy. They're going to assess for high blood pressure. They're going to assess for any diabetes symptoms. They're going to assess for any bleeding symptoms. They're going to assess baby to see how baby's doing. They do assessments on development. They help moms look for work if that's one of mom's goals. They help moms increase their breastfeeding rates. They really just do a variety of different things for the families, but it's all really focused on we want mom to be healthy when she delivers this baby, and we want this baby to be healthy now and forever. And we're seeing outcomes that last up until baby turns. We've been doing research on this for 40 years, so generational outcomes that have increased due to this home visiting program.
Excellent. Thank you. Thank you so much. And then our last presenter is Christina Harrington. Christina Harrington is with the Saginaw County Health Department, and they have, I believe that would be Region 5. I'm from Tuscola, so we won't hold that against you. But so Region 5, and we're going to talk about the Be Well program, which has greatly increased these rates in Saginaw, but part of the Region 5.
Yes. Good morning, and thank you all for letting me talk to you this morning. As a local health officer for the Saginaw County Health Department, much of what you heard about this morning in terms of maternal and child health are what we're doing every day. So we are the boots on the ground organizations that the state is advocating to provide. So many of the services that Dawn highlighted in terms of WIC and family planning and nurse family partnerships are programs that we are providing day in and day out to improve maternal and child health outcomes. And unfortunately, in Saginaw, we have some of the highest infant mortality rates outside of the city of Detroit. We have a lot of complexities, 3.5 times disparities that we see amongst our black babies. So our black babies are dying 3.5 times greater than our white babies in Saginaw. And we have significant challenges. Much of which what we talk about is because our moms are not healthy, because our residents are not healthy. Saginaw is also one of the least healthiest counties in the state of Michigan. So our moms are not healthy before, during, and after pregnancies. And so we're working really hard to try to fill those gaps. But in local public health, it's our job to set the system up. We are the strategists that can make the connections. So you heard a lot about the categorical funding that we get for really critical programs and services. It's local public health's job to make the connections between that, to work with the hospitals in my aim with moms that are seeing increased blood pressure so that when they leave the hospital, they have somewhere to go. We get and wrap our arms around our moms and babies. That's really the job of local public health. Yes, we have mandated touch points of programs and services, but what we've done post-COVID with our infrastructure dollars is really rebuilding that infrastructure to support that work. So that whether you're at the community-based organization, you're at the hospital, you're at the provider office, we're connecting the dots between the programs, because we have to do that to be more effective in what we're doing. We can't just operate in silos, and that's really the crux of what we've created in Saginaw with Be Well, is a partnership and a coalition, realizing two things. One is it's great to have categorical funding, and it's really important to do that, but we have to have an infrastructure and a capacity to react and be responsive to our community's needs. For example, when we know far too many of our babies are dying from unsafe sleep-related conditions, we need to pivot. We need to dig down, look at the data, talk to our moms, have conversations with them, which we've done, and we've learned some really pointed pieces of information. One is they don't always know about those services that we're trying to provide because we're not connecting with them in the way that we need to. And also, they may not trust where they're getting those services, and I think you heard already a little bit about that previously. We know we need the right message delivered by the right messengers, and that we have to do that with local public health, which is the center of the system, and we need the funding to support that from an infrastructure standpoint. So that's really the points I wanted to make today in terms of the space to improve those outcomes, is really allowing locals with boots on the ground. Everything begins and ends locally. I really do support and adhere to that philosophy, and we need those dollars to be able to do this work, and making those connections between those programs is absolutely critical.
So my question for you,
Yes.
no, thank you for being concise. The local health departments, so we've seen the department by state statute, we're required to fund the health departments at a certain level.
Correct.
The money comes here, and then you are going to work with the family nurse, the nurse-family partnership. You're going to work with the, just a second here, I got to get everybody's names correctly, the maternal child health, and you're going to sort of function, in my brain, as a social worker connecting, making sure that the pregnant mom is taken care of. Is that a correct assumption?
Yeah, I think in that lens, it's about really taking a population, right? Because in local public health, it's about what can we do to impact population levels, right? So when we talk about data and statistics, we're looking at those outcomes. So how do we take those outputs and measure those outcomes? And so local public health is constantly assessing that, and then being really that local convener of groups that says, here's an issue, here's where we need to tackle, what are the resources that exist in our community, and how do we best leverage them? So that's really where local health departments, yes, we get that categorical funding coming, but we're also doing so much more at the community level with all of our partners.
Last question, Representative O'Neill.
Yes, thank you, Mr. Chair. And your reference point is this slide here.
Yes.
The connectors of all the resources. The center of the hub is the public health department. And what we've been able to do successfully in Saginaw County is provide a link to all these services and organizations to make those outcomes better. So it's not just a one group. It's a collaborative effort. And I think that's what's important. That's what we as legislators want to see in communities, not only in the health aspect, but in all services that we support. How deep and how wide are they connecting with the community? And this is a great example of that, Mr. Chair, members of this committee, that is working. And these are the type of programs we need to support. So thank you, Ms. Harrington, for being here today and being concise. I know you were on a crunch time, but thank you.
Yes.
And thank you, Mr. Chair, for allowing her to speak.
Yeah. Thank you.
Thank you so much. We have one other individual that filled out a card, Jim Casha. Jim, we have exactly 2.5 minutes according to the clock upstairs, and then we're done. And you're bringing some attention regarding fetal alcohol spectrum. So you have literally 2 minutes.
Okay, I'll go fast. I heard the word mentioned, fetal alcohol spectrum disorder by Sydney, but I couldn't find out how much money they're talking about or what kind of program they're talking about. I've been attending these meetings for 19 years, and I don't hear anything. So in 1973, the first foster adopted child, infant, with a failure to thrive was diagnosed as the first fetal alcohol syndrome case. In 2023, 50 years later, that same doctor, Dr. Kenneth Lyon Jones, diagnosed Nicholas Cruz, the Parkland shooter, with a fetal alcohol spectrum disorder. All right. He stated, the disorder in and of itself causes people to commit murder, and that you can take all the substances you can think of, legal drugs, illegal drugs, whatever, put them together in a bag, tie them in a knot. They don't hold a candle to the damage that alcohol will do to a child's brain in utero. We need to address this. Ethan Crumley, when he was 6 to 9 years old, Child Protective Services failed to protect him. When he was 15, he killed 5 of his classmates. When he was 18 or 19, he appealed his life sentence without parole on the basis that his mother damaged his brain in utero by sharing her wedding celebration drinks with him. Okay? But no one wants to know the truth. So not the sheriff, not the judge, not the prosecutors, not her twin sister, not his defense attorneys, not the governor, not the legislature. And we got to know the truth. We need to fund a Healthy Brains for Children initiative to provide proper prenatal care with an emphasis on eliminating all brain-destroying toxins, but especially alcohol. You can raise alcohol taxes to pay for it. You can sue the alcohol companies to pay for it. You can ask Trump to pay for it.
All right, Jim, with that, sir, 2 minutes, because I got to gavel off for the next committee. Thank you. I'm on our next committee, which is in behavioral health, dealing with substance abuse, and definitely this is something that we are working on. Thank you so much. Just a second here. Representative Steele moves to excuse the absent members, and motion prevails by unanimous consent. There being no further business, the meeting is adjourned.